So, Dr. Cynthia does not need any introduction to all of this. Thank you, sir, for coming in for being available for so long. And I also request his other co-chairpersons, Professor Ashim and Dr. Nandita Thakkar, to start our CPC session. Thank you.
Good morning, ladies and gentlemen. It's a great pleasure for me to be here. And in fact, in front of my Guru, Dr. Subhash Sharma, and with me, Dr. Hashim Das, who is former professor of histopathology at PGI, Dr. Nandita Thakkar, who is the present head of histopathology. And nothing can be more satisfying when you have your student presenting the CPC. Dr. Naveen Khatri is a celebrated hematologist. And Naveen, let me tell you that if we revisit our MD final examination. Yes, sir. Over to you.
Good morning, everyone. I think after 20 years, I'm again nervous as I was when I was giving my MD exam. So first of all, it's a real honor to be here and an honor to present in front of all these seniors of PGI. I couldn't have asked for a better presentation to be done by me because I'm really humbled. And more than that, there's another reason that I feel very honored. I am going to present in front of one of my inspirations in life, Dr. Jed. And as I told him just before we started, that don't drag me here today. So we will go straight to the case. She's a 45-year-old lady who hails from Ludhiana, Punjab. She was admitted at PGI on the 4th of August 2022. She unfortunately died on 23rd of August. Duration of stay was 20 days, and she was admitted under the neurology department. So we've just split up the history in few bits to find out what we felt was relevant. And it may not be relevant, but anyways, you will have to suffer this from my side. So our abnormal behavior and irrelevant talk for 2 weeks was the history. Some gabrat, she was in the altered sensorium, she would remove her clothes inappropriately, she received some treatment from a psychiatrist outside. Then the next important part of the history was she had left-sided weakness for 8 days. Before she came to PGI, and there was some headache and occasional vomiting, and there was some fever for 5 days, which is not really very well defined. Her background, there's some long-term anger management issues from domestic squabble. Not sure how important that is, but yes, that is what was mentioned in the clinical case. There were some behavioral changes for 3 years, and she has been a bit aggressive for 3 months. There's menorrhagia, the hemoglobin remains 7 to 8, hypertensive, probably not treated well. Obstetric history was something we found a bit significant. She has 2 living children and 3 second trimester abortions. On examination, she was conscious but disoriented. The MMSE was not possible at that point of time. Hemodynamically, she looked stable, saturation was 94%, nothing more. In the neurological examination, there was no power in the left upper limb and lower limb. The plexus both were the bilateral plantar plexus, and there was nothing more in the examination. In the investigation, what we see is the hemoglobin was always on the lower side, anything between 6.2 to 8.3. The white cell count was okay till the terminal event when it went up to 10,000. The coag, the first one was normal, the other one was deranged, and that may have been because of sepsis, D-dimer privilegium being high. In the RBC indices, the red tick count was high, 7.71, but when you correct it with the index, it was 2.3. Coombs test was done and that was negative. In the biochemistry, what was striking is that there was a renal dysfunction from the time she got admitted. Perhaps she may have had a renal dysfunction for a longer period. We don't have the reports of the previous, whenever she had some problems. The protein was okay. The globulin may have been a bit raised. That could be relative. The CRP was always high. And well, CRP can be risen because of many reasons, but yes, the CRP was high. And the procal done pre-terminally was high. Since she came with neurological symptoms, the CSF was done thrice, and all the 3 times there was lymphocytosis. Protein was mildly raised. There was nothing else which was positive from what we have been given. She was apparently very obese with hirsutism. So an endocrine profile was done for this patient. Nothing major except that the ACTH looked quite low and the cortisol was borderline and the LH FSH was mildly on the lower side. I'm not sure how much it contributes, but yes, these were the final investigations. Ferritin was mildly raised, B12 was high. Perhaps you may have received supplements outside. Nothing more was contributory. The important was urine protein, which was high, it was 2 grams. And all the autoimmune markers done, the ANA, anti-Ro, lab, ANCA, cryoglobulins, all were negative. Now we'll delve a bit on the scans because it may be one of the investigation which may give us light to the diagnosis. So you can see that this is a T2 weighted flare and the diffusion weighted images from the left to right. And you can see that there are multiple lesions in the bilateral frontal and parietal region, which were hyper intense. And when you look at the frontal region in another axial section, you can see a nodular enhancement also, which was there. And the diffusion weighted image also showed intensity. Now there was also the splenium of the corpus callosum. There was some hyperintensity there too, which also enhanced. And it just tells you that there are multiple solid lesions in the brain. I'll come to what the interpretation was from PGI radiology. which is really abnormal in these. So the PET scan report from PGI showed what I've just mentioned, and it also showed that the cardiac muscle and other subcutaneous tissue were also involved, and muscle deposits, and their likely diagnosis was lymphoma. Now, the LDH was mildly raised. I would have thought the LDH to be very high if it was an aggressive lymphoma. Nevertheless, it was mildly raised. The other tumor markers were negative. The electrophoresis was also done, and there was mild hypergammaglobulinemia. Perhaps that may tell us that there was something wrong even in the biochemistry at that point of time. And marrow was certainly done because PET showed uptake in the marrow. It was hypercellular with cellularity of 70 to 80%, some lymphocytes. The flow cytometry was negative for malignancy, and we'll hear more about it from Dr. Bal, and maybe there's something up the sleeve there too. So the cause is a background of unspecified psychiatric illness with hypertension. She came to PGI at that point of time. There was some anemia, hyponatremia, maybe CKD, hypervinemia, MRI possibly infarcts. Differential diagnosis of CNS symptoms from the team was encephalopathy, malignancy, or CNS vasculitis. All the autoimmune antibodies which they did were negative. Heparin given, antibiotics and antivirals given. She received steroids, and after that, she did have improvement in the neurological symptoms, with the MLSE improving and some improvement in the part of the limbs. The PET-CT done showed the suspicion of malignancy, but we were not sure what it could be. And then, of course, she developed possibly an infection, and then she was not able to be resuscitated because she deteriorated very fast with Enterococcus faecalis sepsis. So, we are not sure what it is. There's a background history, which is important, and we can't neglect. There's a current illness, which may be on the background, and the clinical deterioration, I don't think there's much which I can think of, rather than just being pneumonia, sepsis, and the downhill. Now, in the background, you have obesity, you've got hirsutism, you've got hypertension, menorrhagia, pregnancy loss, which I felt was an important history. There was anemia and chronic renal dysfunction. Maybe there was proteinuria. So is there something which was there from before? Possibly there could have been an autoimmune disorder. It could have been a part of an autoimmune endocrinopathy. I'm not sure, because the obesity certainly looked a lot from the PET scan. And if someone has marked that hirsutism was there, so maybe there is an element there which I'm not clear, but maybe there must be some autoimmune phenomenon looking at all the other investigations done at PGI. So obviously people were thinking on that line. Now, the current illness is a rapid neurological deterioration with adrenal masses, with disseminate deposits, after lesions. To my mind, malignancy remains possibly the more important than infection. I'm not sure all this picture can go with an autoimmune phenomenon, though there is a background of autoimmunity which possibly is there. The clinical deterioration was hospital-acquired infection from what I can understand. Now, I would split it into four: a malignancy, disseminated infection, autoimmune disorders, and endocrine disorders less likely. So what is for malignancy? You have solid FDG-avid lesions. You have CNS manifestation will look like nodular lesions. There was a query that it could be infarct. Course is acute to subacute. What is against is there's no history of constitutional symptoms. The CNS did not have it had non-avid PET lesions. But when you give steroids for some days, the CNS lesions are the first to go. Tumor marker, that's LDH, was not high, or any other tumor marker. Disseminated infection, it could be any of the chronic infections like TB or histoplasmosis, because adrenals are involved in histoplasmosis. So there is a large adrenal mass. But again, there doesn't seem to be any major history of fever, constitutional symptoms. The patient didn't look immune compromised, apart from the fact that maybe some treatment for chronic renal dysfunction or some autoimmunity, I don't know. Autoimmune disorder, I would say it was in the background, if it was, but it doesn't look to be the current illness differential, because the mass lesions do not go with it. And so with the endocrine disorders, which may be tumors, but it really does not fit in, at least in my mind. So likely, possible, unlikely, and the last one, unlikely. Now, I would delve a bit on the bilateral adrenal masses. So, we did review a lot of literature on adrenal masses for this case, and we felt that the adrenal masses, if it's more than 5 to 6 centimeters, there are not too many diagnoses. Lymphoma is one important, histoplasmosis is important, metastasis. Pheochromocytoma, I feel it's possibly not the diagnosis because the typical history was not there. But if you look at the incidence of bilateral adenomasses, it's mostly in pheochroma and cytoma and tuberculosis. Lymphoma, metastasis the incidence is less. When you look at the imaging of the adrenal mass and imaging, to what we've seen in the scan of this lady, it is bilateral. There is some enhancement in the contrast CT, which is not significant, which again tells you that possibly it may be a lymphoma or an infection. And the FDG avidity was very high, which typically happens is adrenal hyperplasia or lymphoma, metastasis. Histoplasmosis, we don't know because I don't think anyone does PET scan for histoplasmosis, but perhaps it would be increased. What is unlikely, what is less likely for infection is that we didn't see any necrosis and maybe calcification, which typically happens in TB and maybe in histoplasmosis to some extent. So my possibilities would be primarily adrenal lymphoma with dissemination, maybe histoplasmosis. Tuberculosis is a third, which I don't think it would be, and maybe an unknown primary with adrenal CNS metastasis. So what is for the primary adrenal lymphoma? Bilateral masses, large masses, avidity in the PET scan, CNS involvement and seen in around 5 to 10% of patients, some improvement is steroid. But what is against that, in my mind, is that CNS manifestation usually does not present as the first in lymphoma unless it's a primary CNS lymphoma. And here I wouldn't really consider primary CNS lymphoma because there's disseminated disease outside the brain, if at all this is a lymphoma. Then the borderline LDH was also something which was not very clear why it would be. This is a review, the largest review of adrenal lymphoma, where you see that the adrenal insufficiency is in 60%. Her cortisol was borderline, so perhaps it does not look different from what her, her investigation was. And in 20%, it's disseminated. Adrenal lymphomas usually going into the marrow, and in this patient too, the marrow seemed uninvolved. In this large series, what has been reported that more than 80% of all adrenal lymphomas are diffuse large B cell, followed by B cell non-specified, and then PTCL. And many of these adrenal lymphomas come with a background of some sort of autoimmunity, and that you can see in that figure A. So there is some, at least hint that perhaps there must be some autoimmunity, if at all this is a lymphoma. And there was hemophagocytosis in the marrow, which also is a part of some of the lymphomas, especially T cell. Disseminated histoplasmosis, subacute clinical cause, avid lesions in the renal in the PET scan. The lymphocytus, pleocytus was there. Possibly there were some vascular infarcts, we don't know. But again, something against it is cortisol being borderline. Usually it's low, no necrosis in the scan. And why would the adnexa and skeletal muscles be involved? That is something which I would not think why it would be from histoplasmosis. However, if you look at endemic histoplasmosis, the northern part of India and the northeast are endemic areas for histoplasmosis. And this series of histoplasma capsulatum in the CNS does show that there is personality changes in a fair bit of patients who present with CNS histoplasmosis, and they have adrenal lesions in at least 1/5 of them. They present like stroke-like. And the same group published again after 10 years with a larger number of patients in the series. And it does suggest that some of these manifestations that we saw in this patient could be with this patient. There's a report from India where again the adrenal hyperfunction, paratic nodes are seen with adrenal lymphoma. Tuberculosis, possibly no, but then, we were always taught that TB is the greatest masquerader of whatever happens in the body. So I would maybe keep it as third or fourth. And adrenal metastasis from a primary unknown, I can't really think. With PET scan, the primary unknown seems to be low because PET will usually show areas which may possibly tell you that it's a primary, and it doesn't really fit into any of the primary, which would be metastasis to the adrenal glands. She deteriorated, and this was all because of pneumonia. So my final impression is, in a background of perhaps an autoimmunity or endocrinopathy, the current illness is possibly in an adrenal lymphoma, maybe histoplasmosis, but I would think that possibly it's a lymphoma. And the terminal event is a hospital-acquired infection. So in CPCs, clinicians are always the losers. I'm sorry if I've heard Dr. Jain for that. If diagnosis is correct, it has been rigged. If the diagnosis is incorrect, you're not a good clinician. So I would hand over to the genius, who's always the pathologist, and there are no doubts about that. Before I end, I would just acknowledge some people who have helped me with this case. It was serious. It was difficult for us. We are no longer in the experience of doing CPC at Tata Memorial Center. So, our brains have got a bit rusted, but we did try to put up something, and let's see if the diagnosis was anywhere near. Nishant, who is my colleague, and he also is an alumni of PGI, a very bright guy, has helped me. And two radiologists, Amit Janu and Nilandu, who are excellent radiologists, have helped me put up this discussion, and let's see what's there in store. Thank you for your attention.
Yes, please come and join me here. So I open the clinical case for discussions. If there are any alternate diagnosis or some points now, the case is yours. Yes, please.
I'm Dr. Shashidharan. I feel it is an inflammatory disorder because CRP is very high. Albumin globulin reversal is there. It looks like a granulomatous vasculitis involving multiple systems. Of course, it can progress to lymphoma subsequently. That's what I feel. And in addition to that, in spite of having frank B12 deficiency, the ferritin is high. That also favors an inflammatory disorder. All are fitting with the granulomatous vasculitis, Churg-Strauss type vasculitis.
Thank you. Yes, next one, please.
I'll take a chance. I used to be on the other side, so I'll take a chance from this side now. Possibilities are, of course, the LDH is the odd thing, and I have a feeling that some of the story lies in the flow of the bone marrow. So the question is, NK cell or T cell disorders, you can have this, massive cytokine release and coagulopathies, etc. And I think the CNS issues are secondary to that. So I'll leave there.
Okay.
Hi, Naveen. Very good presentation. I just was wondering, I didn't hear, maybe I missed it. Was there any further characterization of the type of anemia? I mean, was it, we would presume it might be anemia of malignancy or chronic disorder with high ferritin, but I didn't hear you get into that area. Can you share some?
Yes, sir. So the anemia, the only investigation that we had was reticulocyte count, which was high, but when you correct it, it was not really significantly high. And the ferritin was slightly on the higher side. The B12 and the folate were high. And the iron markers, the iron studies were not done. So, if there is an underlying chronic renal dysfunction, which has been going on for long, perhaps there would be anemia of the chronic renal disease, or whatever is the pathogenesis, it may be related to the chronic anemia of anemia of chronic diseases. There was nothing else that was there in the investigation and history to tell that, I could have characterized it further. Yeah, the marrow did show a cellularity of 18 to 90%, and the erythroid precursors were well preserved. So, it certainly isn't an hypoproliferative marrow. It must be something which must be leading to some destruction or the typical anemia of inflammation.
Yes, sir.
Good morning. Yeah, beautiful presentation. But I couldn't get it. Was it absolute lymphocytosis, or it was just a percentage? Because if it was absolute lymphocytosis, then you can think of the other things. Because you said 80–90% lymphocytes. But what is important is, was it absolute lymphocytosis?
So you're talking about the marrow?
No, from the blood film, from the blood test.
From the peripheral blood.
Peripheral.
The lymphocyte percentage was only 13%.
lymphocyte. percentage
Yes,
only
the neutrophil were 60 to
neutrophils
70%. Yes, sir. And the white cell count was normal till the last day.
Yes, sir.
Yes, sir. The overall tempo of events and the clinical profile makes the diagnosis of primary adrenal lymphoma with dissemination more likely. We can keep LDH and out of the picture because the overall profile fits into that. Only 2 points from my side is when the marrow was done was histoplasmosis actually looked at, because disseminated histoplasmosis would definitely involve the marrow. And he being from Ludhiana does fall in the endogangetic belt where histoplasmosis is not so uncommon. Second thing was the terminal event when there was septic shock refractory to inotropes. We have a setting of adrenal crisis here. I just want to know when DEXA was tapered, he was put on adequate doses of hydrocortisone when that septic shock had intervened post pneumonia.
So there is a history of giving dexamethasone for a few days and then to hydrocortisone for a few days. That is all the, the history which is there. But, if you look at the terminal event, possibly when you have been in the ward for a very long time, if you develop sepsis and, sometimes the antibiotics don't work. So I'm not sure. I mean, I would just put it that there was an hospital acquired infection as a terminal event.
All right, yes, sir.
Thank you, Naveen. So adding to what you said, there is anemia of chronic disease or iron deficiency because of menorrhagia with a nephrotic syndrome with a proteinuria of 2 grams and plus renal failure. With an autoimmunity process, there is a lymphoma process to consider immunodeficiency as a possibility, which is predisposing the whole thing of immune dysregulation and infection, autoimmunity, lymphoma to be considered.
So, we know that autoimmunity in any organ does predispose to lymphomas. Now, whether the immune deficiency was present from before, you will never get to know because you don't really have the history where there were recurrent infections and other part of that history. But certainly looking at all that picture that we have, there is certainly in a background syndrome complex or something where there is some endocrinopathy, there is certainly some, anemia with chronic renal dysfunction, there is menorrhagia, there is something there. I mean, I can only think of those autoimmune polyendocrinopathies type 2, which is not really inherited or may have some genetic defect, but I'm not an expert in all that, but I think I can only say that there was some autoimmunity possibly, and see the workup done is extensive for autoimmunity. So, the unit did think of a possibility.
Hemoglobin levels, I could not find.
I think
No,
we have
there's
to
not.
restrict now to very short comments. Yes, sir.
So I think I must congratulate Khatri for an excellent analysis. Looks like lymphoma with the adrenal involvement, primary adrenal. But if you had involvement of several organs, including the brain, which looks like infarcts, I think a primary intravascular lymphoma is another thing that you should consider.
Yes, sir. We did think of it, and the only reason why I felt that it may not be primary intravascular lymphoma is that their course is more acute, and this lady had a course which was slightly subacute. So, but you are absolutely right. I mean, if it's a lymphoma, it could be any of those 3 or 4 types.
Yes, sir.
Yeah, I'm more pediatric hemonc, so pardon me if I make some incorrect comments, but in the context of autoimmunity for the anemia, one consideration should have been also Coombs test, to see whether autoimmune hemolytic anemia.
It was done. It
done.
was negative.
Negative.
Yes. Yes.
And the second one is, histoplasmosis, for example, I'm from Kentucky in US, we have a lot of endemic histo. I've never seen a histo without a mediastinal mass, my entire practice. So that has to be
Yes.
one of the most important clinical findings.
You're absolutely right, sir. There were some mediastinal nodes, but it wasn't significant. I forgot to mention that. But yes, you're absolutely right that histoplasmosis usually involves the lymph nodes in the mediastinum also, but it can be in other areas. And the other odd point was, well, I'm not an expert in histoplasmosis, but there are bone lesions, there's adnexal lesions, which again looked a bit odd for it, but that's why we kept it as a second
And
diagnosis.
continue along on the autoimmune status, should we do a lupus anticoagulant or ADAMTS13 as other workup for possible strokes?
So the ANA was done, the anti-nuclear antibody, then the anti-Ro and anti-LAM, and then the ANCA was done. So these were the reports that were given to us. So those were all negative.
All right, before we end, it's so interesting to see that the case is discussed as hematology. I doubt if the case was discussed with the surgeon, they would have said CA stomach. And the case was discussed in neurologist, they would have said, primary antiphospholipid antibody. So it all depends on actually who's discussing. Since it's at a hematology forum, I expect that it'll be lymphoma. Is that right?
I don't know.
That's
but I'm
how.
about to tell.
That's how medicine goes on.
The gastric thickening was also significant and the SUV was high, but we just ignored a bit of it. But sir is always right.
No,
So
no,
I can't say.
no, I'm not always right. But what I'm trying to say, that's exactly what happens. And the patient, it is the fortune for, that the person has come to PGI. So finally we have the diagnosis. So with this, I hand over to Amanjeet now to show us what actually transpired. Yes, Amanjeet. Would you please introduce Amanjeet for a minute? Yeah.
Thank you. Hello, can you hear me? Dr. Amanjeet Bal, who is working as a professor of histopathology in this institute only. And she has special interest in breast and pulmonary pathology. But apart from that, she has got a very tremendous interest in lymphoma pathology. Probably from that, you can probably expect that there may be something. I'm not sure. And she had more than 300 publications and 11 chapters in books. This is really an extraordinary achievement. And he has got a numerous extramural funding. So may I request Dr. Amanjeet to present the case?
Thank you, sir, and good morning all. So let's start with the pathology findings. In this 45-year-old female with the clinical diagnosis of disseminated malignancy with unknown primary hospital-acquired pneumonia, refractory septic shock, and secondary HLH, a complete autopsy was performed, and prosectors noted that the patient was obese and had hirsutism. And on opening, the pericardial cavity yielded 150 ml of fluid, and pleural and peritoneal cavities were within normal limits. So since this patient presented with CNS symptoms, so I'll start with the brain findings first. So this is the coronal slice of the brain. The brain overall weighed around 1,134 grams. And if you see here, the marked area, this is an area of softening, which is dominantly present in the white matter, but it's all another area of softening is also seen within the gray matter. So this gross appearance is like infarct within the brain parenchyma. This is another area which is slightly posterior, that is parietal region. Again, we see area of wrinkling of the white matter, and there is granularity in the gray matter. This is the high power to show, and this is grossly suggestive of infarct. More posteriorly, this is occipital lobe. Again, we see an area of rarefaction within the white matter in the occipital lobe. This is a closer view of the same. Now, sections taken from these areas, they do show infarct. So this is a large area of papilla, which is seen in the white matter. And if you see, it's also extending to the cortex, and overlying meninges are thickened, and we can see the prominent blood vessels here. LFB-PA stain, which highlights loss of myelin within the white matter. And there is prominence of blood vessels here. And on closer look, these areas show presence of these macrophages, which are eating up the myelin. So this confirms that this is an area of infarct. So what is the etiology of this infarct? So those were large infarcts which were visible on gross. And then we have these smaller infarcts which are seen only on microscopic examination. And at the edge of these infarcts, you see these small vessels which are showing fibrin thrombi. So both these small areas of infarcts have close by vessels which show fibrin thrombi. Now, closer look at other areas. These are the capillary sized blood vessels of the brain parenchyma, and we see discohesive cells within the lumen. And these cells are large atypical lymphoid cells. And if we do CD20, these are positive for CD20, diffusely bright membranous positivity. So here we see, in addition to these cells, there is some amount of fibrin also. And grossly, we can see these areas, but in addition, CD20 has also picked up even the single cells in a small capillary sized vessels in the brain parenchyma. These are the meningeal vessels. They are also filled with these cells mixed with fibrin. And this is, you can say, a cohesive pattern, which is occluding the lumen of the vessel, which has reduced in size. Another blood vessel, which is showing a margination of these lymphoid cells, and they are sticking to the endothelial cell of the blood vessel. And again, CD20 highlighting these cells which are closely packed within the lumen of the blood vessel. So there was no spillover of these atypical lymphoid cells, which are CD20 positive, into the brain parenchyma. It was limited to different caliber, lumen of the different caliber blood vessels. Now coming to kidneys, both the kidneys together weigh 320 grams. And if you see, there are some cortical scars, there is blotchiness, areas of hemorrhages, as well as the paler areas. Aorta did not show significant atherosclerosis, and close to this, para-aortic lymph nodes appear enlarged. They range from 1.5 centimeter to the smallest, which is like 0.5 centimeter in size. On cut section, the corticomedullary junction is distinct at most of the places, but if you see the cortex, there are pale areas alternating with this congested areas. So there is some infiltrative process is going on in the cortical region. So this is low power of the kidney. If you see, most of the glomeruli are looking cellular, and even focal areas of interstitium are also blue appearing, indicating the increase in cellularity here. The closer look of these glomeruli, almost all the capillaries of the glomerular tuft are filled with these cells, which we just saw in CNS, and they were expanding the capillary lumina. And if you see here, they are also present in the Bowman space, and they are tagging themselves to the Bowman's capsule. Closer look to show the lymphoid cells, atypical lymphoid cells, which are occluding the capillary vessels of the glomeruli. Here, the glomerular tuft has shrunken, and this is the Bowman space, which is again filled with these atypical cells. Occasional glomeruli, which constituted less than 1%, were normal in morphology. They did not show any significant basement thickening, and this is PS10 to highlight very few preserved glomeruli. In addition to the glomeruli, almost all the segmental branches of the renal artery, that's arcuate artery, interlobular arteries, they were filled with these type of atypical lymphoid cells admixed with fibrin. This is another vessel which is showing complete occlusion of the lumina of these arteries and veins. This is CD20 immunostain, and it has beautifully highlighted the cells which are limited to the glomerular capillaries, and they are also seen in these peritubular capillaries. And if the tubules look all right at this magnification. This is closer view to show the CD20 positive lymphoid cells within the glomerular capillaries, within the Bowman space, and in the peritubular capillaries. This is just a closer view to show the bright positive, nice membranous positivity for CD20. This is in the peritubular capillaries, whereas tubules, you can see they are not infiltrated by the disease process. Few of the tubules did show shedding of the lining epithelium. There was some dilatation, and occasional hyaline casts were seen, and this is indicative of acute kidney injury, which is happening because of as a result of ischemia. These are bilateral adrenals, which together weighed 120 grams. And if they are massively enlarged, and the cut surface is what we say a rubbery appearance, which is typical of lymphomatous process. The bulk of the disease was in the adrenals, and there was massive dilatation of the sinusoids, and these lymphoma cell infiltrates are compressing the normal adrenal parenchyma. So this is high power to show only few adrenocortical cells which are preserved, and dominantly it is replaced by lymphomatous process. This is closer view, but here also you can appreciate it's limited to the sinusoids and they are very much expanded that they are causing atrophy of the cortical cells. And this is the morphology. You can see these are having round contour, 1, 2, 3 nucleoli, which are basophilic and beneath the basement membrane. So they are having a centroblast-like morphology. Occasional anaplastic cell was also noted. Diffusely positive. So all the IHC panel was done on adrenal because bulk of disease was there. So CD20 is diffusely positive. This highlights the membranous positivity. CD3 showed few reactive background cells, and BCL2 is also positive in these lymphoma cells. These cells were negative for TDT, in ruling out the immaturity in these lymphoid cells. They were negative for cyclin D1 and SOX11, fairly ruling out mantle cell lymphoma. CD10, BCL6 and MUM1 was also negative, so it does not place it into any category of GCB or non-GCB phenotype. And c-MYC expression was also negative. Since BCL2 was positive, so we were trying to look at double expressor large B-cell lymphoma, so c-MYC was negative, and so was EBAR-ISH and HHV8 in these lymphoma cells. So this is FISH. It was negative for, even though it showed a BCL2 expression, it was negative for BCL2 break apart FISH. It was negative for c-MYC break apart FISH, and it was negative for 11-14 translocation, which is for mantle cell lymphoma. Coming to the lymph nodes, which were only at the focal area in a para-aortic region, we can see it grossly appears involved by the lymphoma process. And remaining lymph nodes on microscopy did not show any lymphomatous infiltration. Only 2 of these lymph nodes show lymphoma infiltration. This is the pattern of infiltration. It was like, maybe you can say it's a large extensive dilatation of the sinuses of the lymph node, and the morphology was similar. Coming to bone marrow, it is hypercellular for age. At this power, we can see adequate representation of all elements. We can see megakaryocytes also. And on higher magnification, the similar cells are noted here and there, but they are not forming a sheeting pattern or a nodular pattern, and they were highlighted by this CD20 immunostain. So they also are present in a sinusoidal pattern of infiltration. In addition, there was some evidence of hemophagocytosis. The macrophages are engulfing the lymphoid cells. So the macrophages were quite prominent in the marrow. Liver weighed 1800 grams and it shows mottling. We can see these hemorrhagic areas alternating with pale areas. The spleen was also enlarged, weighed 456 grams. Gallbladder, pancreas, and C-loop of duodenum was grossly unremarkable. On one aspect, on the right lobe of the liver, the outer capsular surface was thickened and it showed this type of nodularity, and other areas it shows mottling, hemorrhagic areas alternating with pale areas. So this is the low power of liver parenchyma. Here we see the dominant infiltration pattern is within the sinusoidal areas, whereas red pulp showed only few foci of infiltration. And if we see within the portal tracts also, they are looking like they are within the portal vein radicals. They are present within the portal vein radicals. There was one focus which was cavernous hemangioma of the liver, and the lymphomatous cells were also infiltrating in between these walls of those cavernous spaces. This is a closer view to show these are the cavernous spaces and the lymphoma cells are infiltrating in the walls of these cavernous spaces. Rest of the liver parenchyma showed centrizonal congestion. There is dilatation of the sinusoids, and at high power we can see prominence of Kupffer cells which are showing evidence of hemophagocytosis. Spleen grossly did not show any nodularity. It was enlarged, cut surface was hemorrhagic. There was dilatation of the red pulp. White pulp was depleted, but the amount of the tumor cells in this red pulp was very few. There were only few foci of atypical cells in the sinusoids. However, it did show evidence of hemophagocytosis, which is highlighted in the insect. Pancreas were grossly and microscopically unremarkable. Coming to heart, which weighed 320 gram, anterior surface unremarkable except for some dullness on the pericardium. The posterior surface is showing these pinpoint hemorrhagic areas. Right inflow and right outflow did not show any vegetations in the valves and they were unremarkable. This is left inflow and left outflow. The valves were and chambers were within normal limits. However, there were some grayish white areas in the left ventricular wall, which I'll show later. So this is from the papillary muscle. We see the lymphoma cells are just sticking to the endocardial layer of the heart. This is closer view to show a sheet or a layer of lymphoma cells sticking to the endocardium. These are the gray-white areas on the apical slice, and this is one hemorrhagic area on the left ventricular wall, which is grayish-white in the center, and the margin is hemorrhagic. The heart is the only area where there is infiltration outside the blood vessels. So we can see in interstitial infiltrate by these lymphoma cells. So these vessels, they do not act only as a vehicle for these lymphoma cells, they act as a proliferation site also. So when proliferation is in abundance, they can come out of the vessels by force rather than by an extravasation process. So we have extensive infiltration in the interstitium of the heart. Lungs weighed 1300 grams, pleural surface is unremarkable, no pleuritis was noted. Cut section appeared solid and hemorrhagic. And in microscopy, we see presence of this pink eosinophilic hyaline membrane, which is suggestive of diffuse alveolar damage, and its clinical counterpart is ARDS. This is another photograph to show presence of hyaline membrane, which is indicative of diffuse alveolar damage. Even the bronchioles did show some fibrinoid material, which is causing ulceration of the bronchial lining. And if you see, the intraalveolar blood vessels are appearing quite busy, and the cells were present in these interstitial alveolar capillaries, even though they are looking thin, but they were appearing blue. So this is because of these lymphoma cells entrapped in the intraalveolar capillaries. The segmental branches of the pulmonary artery and the pulmonary vein. So this is one interlobular septa. This is pulmonary vein. Again, as we saw in the kidney and the meningeal vessels, the cells are sticking to the endothelial in the form of sheets. And this is CD20 highlighting the same. Stomach, grossly, the folds appear thickened as compared to what we see normally. And if we see again in the lamina propria, these are the capillary-sized vessels which are carrying these cells. And this is the CD20, which highlights these intracapillary lymphoma cells better. This is closer view of the same. Small and large intestine was grossly as well as microscopically unremarkable. Both the adnexas and uterine vessels also showed similar intracapillary lymphoma cells. This is skeletal muscles. So blood vessels within the skeletal muscles showed presence of this lymphomatous process. The skin biopsy, the superficial dermis is unremarkable. However, the capillaries in the subcutaneous fat are showing presence of these lymphoma cells, and it is also associated with fibrin. So whenever clinicians take skin biopsies, if they are taking a superficial biopsy, it may be missed because these cells are residing in the blood vessels within the subcutaneous fat. So what we are dealing with is an intravascular large B-cell lymphoma, which is defined as an intravascular proliferation of clonal lymphocytes with little or no involvement of the organ parenchyma. And since 4th edition of WHO, it is a distinct entity. And usually it involves the extranodal organs, and the lymph nodes, marrow, and spleen are spared. But we did have some evidence of infiltration in the lymph nodes, spleen, and the bone marrow. The reason is they are expressing some of the markers which adhere them to the endothelial cells of the blood vessels, and they are lacking some markers like CD29 and 54, which is preventing their transvascular migration, that is extravasation. So we can have extravascular component, but it depends, it should be predominant intravascular, and some extravascular component is allowed in a category of intravascular large B-cell lymphoma. So in this 45-year-old female, we have intravascular large B-cell lymphoma involving brain where it is causing infarcts, bilateral adrenals, kidneys, heart, lungs, liver, spleen, stomach, bone marrow, lymph nodes, skeletal muscle, and almost all the organs. There is evidence of secondary hemophagocytic lymphohistiocytosis, which is seen in bone marrow, liver, and spleen, and there is evidence of diffuse alveolar damage in the exudative phase. So just wanted to share two previous cases of intravascular large B-cell lymphoma, and both these CPCs were done by Professor Ashim Das. One presented as acute renal failure with nephrolithasis, and the second was a 45-year-old male which presented as a non-compressive myelopathy and urosepsis. Unfortunately, in both these cases, partial autopsy was done and brain was not examined. Thank you.
Thank you, Aman. Thank you, Amanjeet. Please come and join me. Now, both the clinical and pathology protocol are open. Yes, I think
It's working? No. Hello. Yes, before we begin the discussion, we just tell that clinico-pathological exercise is only a teaching learning exercise. There is nobody is loser and nobody is gainer. Only gain is our knowledge. So this is the thing which I just wanted, then we can start the whole discussion.
Yeah, I just fantastic case, and I think a lot of learnings in this presentation. I just was wondering, for the sake of completeness, I would have expected some mention of the light chain restriction in this case, whether it was kappa or lambda, because scientifically we cannot call a disease as a lymphoma unless you show clonality. And the clonality in the case of a B-cell lymphoma has to be proven by light chain restriction study. So I was just wondering, it must have been done, but maybe you didn't mention that.
yes, Uday, please.
Excellent presentation by both the presenters. There are a few still unanswered questions in the mind of a clinician. Three of those. Firstly, the patient has a very long history, and as Naveen sir was mentioning, IVLs are acute in presentation. How do we explain pregnancy losses? How do we explain hirsutism, obesity of such long duration? And here in the autopsy, lymphoma is everywhere. That's query number one. Query number two, as a clinician, what could have done differently to diagnose this patient ante-mortem such that something could have been done? And a bone marrow was done as a clinician and we didn't find anything there. So what else could we have done ante-mortem? And the last point, patient did receive dexamethasone and also hydrocortisone, and still we are having lymphoma everywhere. Something which I would like to take with a pinch of salt. Not that we are doubting the diagnosis, but somehow, like as a clinician, very difficult to diagnose this ante-mortem with the available picture.
Yes, I think, all these are medical questions which I can answer very easily, why this person is having all these endocrine problems. Ladies who have hirsutism, who has got, acne, obesity, the first diagnosis is that of polycystic ovarian disease, although we have not been shown, and I doubt very much. The hormonal profile is not that of PCOS, but these things are very common with the obese ladies, but the workup is not complete. Point number one. Number two, how could we have done? It all depends, as I said, where the patient lands up. The person has landed up in neurology. Had this been with the gastroenterology, a simple upper GI endoscopy or gastric biopsy would have changed the diagnosis. If the person was possibly with internal medicine, we will put a needle in the adrenal gland straight. So, it all depends, and that's how the medical field unfolds. Possibly here, the main emphasis was on managing this person and salvaging this individual, and possibly that was the reason that there was some, you may say, delay or orientation. And as far as the pathology question, I think Amanjeet, would you like to answer?
So we have not done kappa and light chain for clonality in this case, and because morphology is quite suggestive of a lymphomatous process, so we take it as a clonal process. And secondly, most of these lymphomas, they like majority of cases have shown bilateral adrenal involvement, and these patients, they do present with endocrinopathies, and there are reports of thyroid involvement as well as pituitary involvement. So endocrinopathy as a presenting symptom is a possibility. And the cases, if you are suspecting lymphoma and there is no organomegaly, then they recommend doing a skin biopsy, even from a normal looking skin, but it should be a deeper where you should get a subcutaneous tissue, as well as the transbronchial lung biopsies.
Can I just, regarding this clonality, this is only applicable in case of low-grade lymphomas. For a high-grade lymphoma, no histopathologist will do clonality because there is no need for that because the lymphocytes will be more than twice the size. It is looking like a centroblastic morphology. So I don't think this is applicable in case of a high-grade non-Hodgkin lymphoma.
Yes, Nishan.
Ma'am, my question is for you. From what I understand, the adrenal does not have lymphatics, right? So intravascular DLBCL, how often does it involve the adrenals? Because in the slide that you presented, it's not very common. Is it a possibility that this patient had an DLBCL of the adrenals, which had hematogenous spread? I mean, it's known that adrenal is most important predisposing factor for a CNS metastasis. Because the adrenal does not have lymphatics, whatever lymphoma is going to be there in the adrenals, it's going to be in the parenchyma or the sinusoids, or because it's a vascular organ. So if, because adrenal DLBCL is so rare, I mean, if you do it in patients and if you actively do the autopsy or do the pathology of random areas, would you still not find lymphoma confined to the vessels in a patient who has adrenal lymphoma and has a hematogenous metastasis?
Chicken or the egg story, which came first? Is it the adrenal or which has gone into the vessels, or is it the vessels which has gone to the adrenal? And you can keep on debating. I don't think you can.
So that's what sir also showed. We actually I had read about this because the adrenal involvement is very, very rare in an intravascular DLBCL. I would still think with such huge masses and a chronic anemia and all these things, the patient possibly had an adrenal lymphoma. And when we caught the patient, it had spread hematogenously to all these organs that we found.
Yes, Malik.
Good morning. Krishnan from North Carolina, United States. Listening to this CPC, it just reminds me of the glamour of this program, which has sustained itself over the years. And it has been heartwarming to listen to the presentation, both clinically and pathologically. I had a question which was actually also asked by another. How do you suspect this clinically, and how do we establish this diagnosis when you have a patient who you know is lymphoma, but you do not know it may be intravascular or not? I know Amanjeet mentioned deep biopsies, but is there any clue that we could have clinically that would force us to do a deep biopsy? Or is there any other method that is available in your experience to establish this diagnosis? Because clinically, we do not have much data on how we're going to go about treating this. We would probably treat it like an aggressive large cell lymphoma. Any clues from your experience?
Yes, I would tell you that from a clinician's perspective, anybody who has a pressure of 200, the first investigation will be ultrasound abdomen. And there is no reason that ultrasound abdomen will not pick up adrenal masses. And once you have the adrenal masses, you have the clue straight. After you rule out pheochromocytoma by doing a simple urinary biochemistry, you would know that metanephrin are not high. You know there is something which is abnormal. And on the top of it, you have a PET scan which is showing multiple deposits everywhere in the scapula, in the subcutaneous tissues, and you can always direct. And now we have the PET guided biopsy. So I believe that if given today, if the right suspicion is there, the diagnosis would be established in 48 hours.
Ashim, I had one other question. In your experience of intravascular, how often do you see the adrenal involvement? Could you not have an intravascular lymphoma without the adrenal involvement?
No, we did not see. But the question is that intravascular large B-cell lymphoma is called the neoplasm of the homeless lymphocytes. But they don't have receptor to recognize their home like lymph node. So that's why they circulate in the smaller vessels, where the endothelial cells aberrantly expresses one receptor by which they stick to the vessels. So only way is that good clinical suspicion and probably a skin biopsy or a Even people advocate the kidney biopsy. Kidney is always involved. But nobody has talked about lymph node involvement in intravascular large B-cell lymphoma.
So I'll just give one comment. So, the only problem with the intravascular lymphoma is because it's widespread and one organ is usually not the major suspect. I would tend to agree to what Nishant did say that, with such bulky adrenals, I would also tend to think that, because the adrenal had a lot of proliferation because of these lymphocytes there, it may have been as Dr. Jain said, chicken or egg, but certainly what strikes as an intravascular lymphoma is the CNS infarct, the renal dysfunction to some extent, because, there has to be something in the vessel which will go. But would it be just a DLBCL going there, or would it be a in situ primary intravascular lymphoma? Always will remain a question to me.
Yes, Molly, 30 seconds, please.
Just to respond to Dr. Krishnan's comment, a question to Dr. Aseem Das about how can you suspect it? We have published 4 cases of intravascular lymphomas, and in none of them it was suspected beforehand. So it's very difficult. Like you said, it's a lymphoma of homeless lymphocytes. It often doesn't have visceromegaly or lymphadenopathy. And however high your index of suspicion, you're gonna miss it. Yes, ma'am.
So just add to the chicken or egg stories and sharing our personal experience. I also have a slight problem in, a lot of lymph nodes involved and calling this as intravascular DLBCL, but I think that's besides the point. From a personal experience, what we do in a suspected patient with lymphoma who is not necessarily bulky, not necessarily masses in the adrenal, even with the slightly bulky adrenals, we go for a deep-seated skin biopsy as ma'am shared. And the second thing we found, 2 other organs that are often involved, but can be challenging to get is TBL, the transbronchial lung biopsy. But we also get a very good deep trephine biopsy and look at the vessels in the trephine. And that has been able to help us pick up. And that is why I wanted to ask Naveen whether they had the benefit of trephine biopsy being reported in this particular patient because the bone marrow was done.
So whatever reports we had was, whatever we have, the marrow showed cellularity and lymphocytes and,
But there immunostains done on the trephine biopsy, looking at the blood vessels within the trephine?
This was trephine biopsy.
Oh, okay.
Yes.
All right, with this we
But
come
the clinician's difficulty here was the LDH was normal.
Yeah.
In this particular patient, you would have seen a lot of visceromegaly. And once that was there, the train of thoughts would have been totally different. See, the problem is it went to.
It's okay, sir. It happens in medicine all the time. That's
No,
all right.
it is not like that. Means many times this is what has happened. Means before all these days of ultrasound things, I have seen constrictive pericarditis reaching in the gastroenterology department as Budd-Chiari syndrome. This I have seen. So this happens.
So the presentation was neurological. That's why.
Yes, thank you very much. And with this, I must say that I would give Naveen 95 out of 100. So he passes this test too with distinction.